Lovely people, happy Thursday. Welcome to yet another iteration of VMR. Very, very happy to have you here. I get to enjoy the fact that this is a first time discussion with one of our beloved team members who is coming off a night shift. Um, yes, those of you who've seen the email, I get to discuss with Eugene, who's been part of the team for several months now. But I think most of you would doubt that that is true and think that he's been part of this space for years. He's presented so many cases, done so many teaching points, uh, jotted down the whiteboard for you all so much. And I think uh, he actually he actually messaged me. Sorry, Eugene, for revealing personal details. He actually messaged me a few days ago uh, uh, as he was writing his personal statement, and I'm going to pull it up exactly to the same word. He said, "Dr. Rabih, I don't know why you call me Dr. Rabih still, but he does. He's one of the few who's like, what do you think of me as?" To kind of help him brainstorm some ideas for his personal statement. And here's exactly what I said. I didn't even like sugarcoat it. I said kind, hardworking, curious, and collaborative. Um, and I think the best part about Eugene, and actually the most illustrative thing about Eugene, is not any of those things, but how he responds. And here's exactly how he responded. He said, "Yep, that's me." Big smile. uh, Eugene, you're universally beloved in this space and probably in every space you exist because of all these traits that you have, but most importantly, your kindness, your warmth, and how you just treat other people. And so we're very, very excited to celebrate you today by giving you probably a very, very hard case to discuss, but we'll get to do it together. Let me hand the mic to you to say hello, and then we'll thank everybody else who's making it happen.
Yeah, hello everyone. Thank you so much, Dr. Ravi, for that elaborate description of me. So I'm Eugene from Ghana. I'm a medical officer, applying to internal medicine this year. Also kind of like do a bit of research on the side. So last week, for instance, I was away for a research training. And then this week I'm back to the clinic, having some night shifts. I have another one tonight and then tomorrow. So kind of excited for VJ. VJ is like a brother. I sometimes message him on the side when I have a difficult case, and he's just so rich in knowledge. I'm a bit nervous because I know he doesn't bring simple cases, but I'm excited for his case. Yeah.
Yeah, I couldn't agree more. VJ, mic to you, please.
Hello everyone, this is Vijay, one of the CP Solvers team member. I'm really excited to present this case. I got this case as a consult, so I think there's a lot of rich understanding and points that we can learn from this case. And I'm really happy to present after a very long time.
It's been a minute, VJ. I still remember some of the legendary cases you presented, and very, very excited for yet another one to list. But before we jump in, let's give a big round of applause to the two people who are making this happen. First is Vinny, who's scribing today. Mic to you, Vinny.
Yeah, so hey everybody, super excited for VJK's energy discussion. Let's go.
Let's go indeed. And Simi is doing teacher points. I'll hand the mic to you, Simi.
Hello everyone, very excited to do teaching points today, and I cannot think straight during the daytime, and Eugene is doing discussion after a night shift, so very inspiring and very excited.
I couldn't agree more. All right, VJ, we're ready whenever you are.
The 21-year-old gentleman presenting with abdominal pain for 2 years. So coming to the HPI, so the patient noticed dull aching, diffuse, mild abdominal pain. It is about 3 out of 10 in intensity, and it increases on working or running. It is non-radiating with no relation to meals or nighttime awakening. So this has been there for the past, it has been persistent with no relief in symptoms. Associated patient has history of fatigue and weight loss of about 10 kgs. Coming to the other negative relevant history. So the patient denies history of any recent travels, denies history of fevers, nausea, vomiting, or oral intake, reduced oral intake, denies any altered bowel habits, jaundice, rash, arthralgia, or ulcers, mucosal ulcers. I'll stop here.
Wow, very, very interesting. Yeah, Eugene, this is a very interesting HPI. I'm curious what you're making of it.
Yeah, thank you so much, VJ. That's a very powerful HPI and presenting complaint. So abdominal pain, I mean, what I usually have this mental thing that I do whenever I get a presenting complaint. And that is to try to get the definition clearly and then also try to localize specifically where the symptom is coming from. And so VJ has described this abdominal pain as diffuse and 3 out of 10 in intensity, and it's persistent. And the characteristic is that this patient has been having this diffuse abdominal pain for the past 2 years. And I'm just trying to understand what prompted this patient to actually come in at this time, what they've been doing in the past. And when you have diffuse abdominal pain, it's a bit difficult to try to pinpoint a specific area of the abdominal pain because, for instance, if you have right upper quadrant pain, you can start localizing to certain organs in the right upper quadrant. If you have left, if you have mid umbilical, but if you have diffuse abdominal pain, then you want to start thinking, is it at the serosal area, depending on how the patient characterizes it. Is it in the peritoneum? Or could this be a vascular issue that is presenting in a diffuse nature? Also, whenever I hear abdominal pain in a diffuse way, I do not want to get food and miss out other areas of the body that could be radiating to the abdomen. So, for instance, in the chest area. If I'm able to characterize this properly, then that can guide me to the physiology behind it. Usually, if you have a sharp or sudden abdominal pain, you can start thinking of a vascular cause that is more of a ischemic event. But if you're thinking about diffuse, then inflammatory jumps up to my head. So these are the pieces that I have so far. It's not yet clear to me why this patient is coming at this time. And so I want that to be quite clear. And then I also want to understand exactly the nature of this pain, aside it being diffuse. Is it colicky? Does it come and go within these past 2 years? Is it intermittent? Is it just as the patient is just as the patient is described? Is it dull or is it actually intense? Does it come with eating? Does it come with hunger? I want to understand all these bits as we get more data. So this is where I am at the moment, and then I would give the mic back to you, Dr. Rabih.
Yeah, no, I value that tremendously. You're using the here, let me you're using tremendously the location, diffuse, the nature, dull, and the duration, chronic, to a tremendous advantage for you. And I think one other parallel way to make progress is to study what consequences the patient has accumulated as a result of this issue. And you can't do that for acute pain syndromes, because most of the time when somebody has an acute pain syndrome, they come right away and they have not accumulated any consequences of the discomfort. But by the time somebody has had discomfort for 2 years, you ask yourself, well, what is the purpose of that discomfort? What is it telling the patient? And why is the fire alarm going on for 2 years? And if you study the consequences here, the consequences are that the patient has lost 10 kilograms of weight. And so if this process continues, then the patient will lose all his weight eventually. And so the goal is to prevent that from happening. And you might ask yourself, okay, what is the significance of a 10-kilogram weight loss? And I find that to be an intriguing amount, because what that means is he's lost 10 kilograms over 24 months, which means that he's losing less than half a kilogram per month. And if somebody were to lose half a kilogram per month, I don't think that that would really catch many people's attention. So the question is this weight loss actually significant and is it related to this process? And I find that very, very intriguing. It's not just intriguing because of the very mild nature of the weight loss over the period of time, but it's also intriguing because the patient continues to be able to eat without consequences. So you might ask yourself, why would somebody have abdominal pain and yet be able to eat? And what does that tell us? It tells us to some degree that the bowel is still happy, the vessels are still happy, the pancreas is happy, the biliary system is happy. So what's left in the belly that can raise the fire alarm, and yet the main function of the abdomen to ingest and digest food is still intact? So for me, I'm really, really intrigued, and I'm wondering where this problem lives, because it doesn't seem to be very consumptive and it doesn't seem to affect the main function of the belly, which is to eat. And yet it seems to be prominently present when the patient exerts himself. And that really should trigger the hypothesis of, well, why does the belly care when it moves? It's not like the heart or the lungs or the legs. And I think that's the thought exercise that we should come back to after we get more information. But it's definitely a very important thought exercise to do, is why does the belly care when you're moving? But I think the main principle that Eugene is getting at is now we have to figure out, okay, what consequences are there to this problem? Is the patient anemic? Is the patient have kidney dysfunction? Does the patient have subtle inflammation? And I think those will be really, really interesting to discover. So a lot of work left to do, but I'm sure Vijay will take us on that journey to do so. So Mike, to you, Vijay.
Yeah, very interesting thought. So I'll give some more data on little about the abdominal pain. So the patient had a very vague, diffuse abdominal pain. So it did not really affect his daily activities. And but however, it was present throughout the day. He described like it as a dull aching or a dragging kind of a pain. Coming to the past medical history, there is history of elevated creatinine that was noticed incidentally while evaluating for this abdominal pain. And the baseline creatinine was found to be 1.9. And on evaluation, found to have 3+ proteinuria, and a diagnosis of renal amyloidosis was made. And further, there is no further evaluation that was pursued, and patient was treated symptomatically for this abdominal pain. Coming to the medication history, so there is a short course of steroid that the patient received. Apart from that, the patient also received anti-tubercular therapy. There is no confirmed diagnosis, but however, in view of the weight loss and this vague abdominal pain, the patient received 6 months of anti-tubercular therapy. Also, at that point of time, a CT abdomen was done that showed mesenteric lymphadenopathy of 2 cm, diffuse multiple mesenteric lymph nodes of 2 cm. And so this is the family history was not relevant. Social health related allergies are not relevant. Everything was normal. There's no history of any recent travels as well. Coming to the examination, everything was normal. Vitals was fine. Patient was comfortably on the bed. And on examination, we found a massive hepatosplenomegaly. And that's it. And there is no edema or anything of that sort. BP was normal, 130/80. The rest of the examination was unremarkable except for a hepatosplenomegaly. 16 cm was the liver and spleen was about 14 cm.
Fascinating, Vijay. Thank you so much. This is very, very interesting. Yeah, Eugene, how has your calculus changed now?
Yeah, the additional data is quite helpful because we have a young patient who has abdominal pain, diffuse, that seems to occur when they are moving, with no significant associated findings except 2 years of weight loss, which we can't really pinpoint to be as really significant for this abdominal pain. And we are now hearing that this patient has been treated for TB and also has been diagnosed of renal amyloidosis. So at this point, first of all, like I said in the initial article, that when you're hearing abdominal pain, diffuse in nature, and just as Rabih, you made it clearer, you want to think about certain areas in the abdomen. We've been able to bring out that it's not really as a result of the function of the bowel, because this patient is eating, this patient is maybe passing stools normally and everything. But then something is still going on in the abdomen that is causing this diffuse pain, especially with movement. So the physiology behind it that sinks to me could be that this could be inflammatory. We are seeing in the CT scan mesenteric lymphadenitis, which could literally be there whenever there's any form of infection. So any form of infection in the abdomen, it could even be a normal enteritis, or it could even be some form of infection in the blood. You could have mesenteric lymphadenitis. So that could explain this diffuse abdominal pain. But the fact that this patient has received anti-TB medications, that is also bringing my mind to think of some form of consequence of the TB in the abdomen. It's not so clear to me yet, but it's just bringing my mind to some sort of consequence of the TB, because we're also having on the examination finding this patient having a massive hepatosplenomegaly. So I'm wondering what is it the amyloidosis or is it the TB that is bringing this picture of hepatosplenomegaly? So that is where my mind is at the moment. If I'm asking myself what next to do to actually get clarity on this patient's abdominal pain, I would want to probably look at maybe a new CT scan and just understand, because this old CT scan just mentioned mesenteric lymphadenopathy. So I want to have a new CT scan to understand what at all is going on. Is there a space occupying lesion that is reflecting with this hepatosplenomegaly? So that's where it's just scattered pieces of thoughts. It's still not clear to me yet where I'm driving at. So I want some imaging to have clarity, and then I will also want to do some blood work to understand why this patient is having this long-term weight loss. So some the lab work of full blood counts, maybe if I'm seeing elevated white cells, that could guide my mind to start thinking of some either myeloproliferative or some kind of other proliferative disease that is leading to this hepatosplenomegaly. Because if you pick hepatosplenomegaly on its own, there could be a vast causes. And so if you're looking at the lymphoproliferative states, if we look at the full blood counts, we can start having some ideas. I'll also be thinking about doing some viral serologies like EBV, CMV, even HIV, to have an understanding of why this patient is having this strain of hepatosplenomegaly. And then I would also want to go ahead and then think along the line of why is this, this renal amyloidosis. I would also want to look at how the kidneys are functioning at the moment. If the patient has a good kidney function test at the moment. So that's where my mind is, just scattered thoughts. Yeah, so Mike, back to you, Rabih.
Yeah, I think, Eugene, you're illustrating that here, let me mute you. That the conversation no longer focuses on the patient's description of the disease, because a more detailed description has been already obtained. And so I think you're not going to make much progress studying the nature of the abdominal pain, nor whether it's with walking or running or the weight loss. You now have a much more clear picture of what's happening inside the abdomen, with an involvement of three major organs: the liver, the spleen, and the kidney. And you have one very powerful piece of information on one of those three organs, the kidney, in that it seems to be diseased in the form of amyloidosis. And renal amyloidosis comes in many flavors. It can come either as part of a systemic amyloidosis, from light chain amyloidosis, AL, or from chronic inflammation, serum amyloid A. There are also isolated renal versions of amyloidosis that can happen. And those are either hereditary conditions, which are probably the dominant form, but then there are other ones that are acquired. So I think the piece of information that can help you make tremendous progress right now, and maybe we can ask Vijay if he knows this, if we know what form of renal amyloidosis he has on that biopsy. Did he have light chain deposition, or was it serum amyloid A that was deposited? Do we know, Vijay?
It was serum amyloid. So the biopsy report that I have was
Yeah.
Yeah, just a second. So it was negative for immunoglobulins and light chains.
Awesome. Okay, that's very, very helpful. So
This is all that we have.
that's all that you have. Okay. So yeah, Eugene, the most common form of renal amyloidosis worldwide is amyloidosis as a result of accumulation of serum amyloid A, a protein that the liver makes as a result of chronic untreated inflammation. And so I think that would be the presumptive hypothesis of what the amyloid is, recognizing that other versions, AL light chain amyloidosis, do occur, which appear to be less likely in this patient based on the negative immunostaining. There are, again, other forms of renal amyloidosis, but those are less likely to occur in the context of a systemic syndrome. So how does that help us? What renal amyloidosis tells you, if it's of the serum A type, is that this patient has had chronic, long-standing, low-grade inflammation. So if you're thinking sepsis, renal amyloidosis is 1 over sepsis. It's the exact opposite, slow, consumptive inflammation. And so you start to wonder, this 21-year-old man has had this disease for such a long time that now you're open to the possibility of things that are very, very old, and probably been affecting him for years, if not decades. And as is true for sepsis, the renal amyloidosis is just a consequence of that undertreated inflammation. So pursuing it will just give you a proportion of how bad this disease is. It will not tell you what or where the disease is. In general, renal amyloidosis in the United States represents a chronic, undertreated inflammatory disease. But in many parts of the world, it often represents infections. And that's probably why the patient was treated with tuberculosis, is the base rate in India is likely TB. So you're right. We have to get a lot more information to understand what's going on. And the next layer is to reassess the information we have with the blood work you mentioned and the imaging you mentioned to see what progress we make. Mike to you, Vijay.
Coming to the next report, so I'll give you some relevant labs. So the hemoglobin was 8.1 with an MCV of 82 and an MCHC of 28. The baseline hemoglobin also at the point of diagnosis was 8.4. The total count was 14.3, platelet of 414, bilirubin being normal, total protein of 6.86, and an albumin of 2.5, and a globulin of 4.4. AST 21, ALT 8, alkaline phosphatase 316. The lab cutoff here was 200. Urea 98, creatinine 6.18, calcium 8, phosphorus 5.36, LDH 97, ferritin 1255, TSAT of 10%, and a PTH of 240. The ESR was 120, the CRP was 65, and an IL-6 level was 6.7. Viral serologies, HIV, HBsAg, HCV were non-reactive. There's a PET CT done 2 months prior to the presentation in our hospital. So it showed low avidity of lymph node, multiple lymph nodes in the abdomen as well as mediastinum. Mediastinum had subcentimetric lymph nodes. Abdomen had diffuse multiple lymph nodes, along with a hepatosplenomegaly, 16 centimeter of liver, and a spleen of 14 centimeter. So we went ahead and did the biopsy was done 2 months prior as well of the mesenteric lymph node. It showed mild plasmacytosis with no kappa lambda restriction, no amyloid deposits, no evidence of lymphoma, granuloma, necrosis, or atypical cells. The urine ACR and PCR were high. The urine ACR was 1807 and the PCR was 16.6. The lab cutoff is less than 0.2. And the lymph node biopsy was negative for acid-fast bacilli or TB PCR. I'll stop at this.
Eugene, I warned you. This is a really tough case to begin to dissect and analyze. I'm curious, what labs did you find the most relevant? What are you inclined to study the most?
Yeah, the hematology labs are abnormal to me, and then the chemistries. I'll take the hematology first. So you have low Ag, but before that, I want to get the calcium. I think that was mentioned, but I can't see it on the whiteboard. Okay, 8. That's great. Okay, so we have a long-standing inflammatory condition, granulomatous, or well, I'm not too sure yet, granulomatous. So probably from tuberculosis that this patient is having, with consequences of amyloidosis in the kidneys, also having massive hepatosplenomegaly, and we are having HB of 8.1, baseline of 8.4. So this patient already has been having low hemoglobin levels. And so I'm wondering, could this be because when you have anemia, you're thinking about, is it at the level of the marrow production? Is it as a result of some hemolysis, or is it as a result of reduction in intake of nutrients that will help with the production of hemoglobin? And where my radar is at the moment could be in 2 areas. Either it could be at the area of the production, or it could be just at the area of maybe consumption. So consumption in that, because we have splenomegaly, I'm wondering if there's some form of splenic sequestration here where the red blood cells, maybe they are not in the normal form, so there's some form of splenic sequestration, or there's some form of infiltration of the marrow space, a space occupying lesion that is causing reduction in this hemoglobin level. The platelet is not abnormal. I know 150 to 450, so I'm not going to talk so much about that. But when you come down to the chemistries, we are having, is the parathyroid increase 240? I'm not so sure. But if it's increased, I would suspect that maybe it's as a result of this because in a granulomatous disease, you can have this parathyroid-like, I think, yeah, parathyroid-like protein. I'm not so sure of the word to use, but that would lead to the increased production of parathyroid hormone. And I'm suspecting that with that increase, that should have caused increase in calcium levels, but we have normal calcium. And so my thoughts, if I am to summarize, we have a chronic inflammatory condition with consequences in the kidney, in the liver, and we are having a PET scan and a biopsy that is showing some mild plasmacytosis. So I'm thinking that this could just be maybe just an abnormal paraproteinemia. I'm not so sure, but that's where my thoughts are at the moment. Yeah. So Mike, back to you, Abby.
Yeah, it's a very difficult case. And I think the core exercise that we have to do is a simple one, but the difficulty level here is high. And it actually is the same exercise we all do every time you get
a patient who has a leukocytosis, and you're trying to figure out, is the leukocytosis the problem? Which is definitely the case when the leukocytosis turns out to be from blasts? Or is the leukocytosis reactive to a problem elsewhere, which is the case when the leukocytosis is neutrophilic? And we have to do this exercise with the whole case. Is the alk phos consequence, like neutrophilia, or is it cause, like blasts? Is the proteinuria consequence or cause? And just like acute neutrophilia is evocative of acute infection, patients having chronic neutrophilia, anemia, thrombocytosis, hepatosplenomegaly with proteinuria, all of it can collapse to a simple explanation, with all of it being the consequence of systemic renal serum amyloid A. And it can explain everything. So we have an undefined antigenic trigger of inflammation that classically causes neutrophilia, anemia, thrombocytosis, that causes AA amyloidosis, which infiltrates the liver, causing alk phos elevation, infiltrates the spleen, causing splenomegaly, and causes proteinuric kidney disease. So what could be happening is the ultimate underlying cause is hidden and is somewhere else we have not looked. And it is now camouflaged by the body's response hematologically with the CBC and the thrombocytosis, and pathologically with the deposition of serum amyloid A in the liver, in the kidney, and in the spleen. Alternatively, the driver of this process may be hiding within its own response. So say the problem is in the spleen itself, and there is, in addition to the problem, the core issue, there is amyloid A deposition. And this is the difficulty in this case, which is, where do you go to pursue the problem? And you have to go to the site of asymmetry. That doesn't make sense. So if Vijay told us there's a large necrotizing lung mass, then we know that everything else is a response to that necrotizing lung mass. So the question for all of us is there asymmetry? And for me, there are two pieces of asymmetry. The first is that the lymph nodes did not detect amyloid deposition, which implies that either the lymph node biopsy was not adequate to detect this abnormality, or that the lymphadenopathy is not the result of serum amyloid A accumulation. This case rests so much on the validity of that renal amyloidosis, AA amyloidosis diagnosis. And since the patient's proteinuria continues to be marked and severe, one point of clarification for us should be to try to pursue this diagnosis and see if it's accurate or not. So I would initiate a full workup for nephrotic range proteinuria, including an HIV, a syphilis, ANA, complements, phospholipase A2 receptor, and if negative, would probably consider a renal biopsy to say, are we right about this amyloid A diagnosis? Because if it's true, it's camouflaging the whole picture. If it's wrong, then we're solving completely the wrong problem. The other point of asymmetry, Eugene, here is that the plasmacytosis is very, very unusual in this space and evokes a specific differential, which I would pursue. The accumulation of plasma cells it can be a signature to infections, autoimmune diseases, and cancers. The main cancer we think about with plasma cells is multiple myeloma and its equivalents, but it actually can also be a feature of Castleman's disease and the spectrum of Castleman's disease. The main autoimmune disease associated with plasma cells on biopsy counterintuitively is rheumatoid arthritis. And the main infection associated with plasma cell accumulation is syphilis. So I think both of those, an RPR would be a simple test here to evaluate the possibility of syphilis. But this is a very rare and complex case. And those of you who are in the beginning of your journey of medicine will be overwhelmed from it. So I will reemphasize the simple learning points here. When something is happening to the body, my left hand, the body responds. And what we're trying to figure out here is, of the data we're getting, which category do we put it in? Do we put it in as the core issue, or do we put it in as the response? And here, if this response is very compatible with AA amyloidosis, very, very compatible. The problem is we haven't found a reason for the AA amyloidosis. First have to question whether the AA amyloidosis is the valid explanation for the hepatosplenomegaly, lymphadenopathy, and proteinuria. And so far, with our biopsy and our data before our eyes, that has been unrevealing. So I would completely disentangle this case and acknowledge that AA amyloidosis is a reasonable explanation, but I think we need to verify that before we assume that that's true. All right, Vijay, what do you have in store for us next?
Discussion. So this was something that was going on in the treating team's mind as well. So two things that are not fitting in. So the same questions that we had was, is the nephrotic syndrome truly amyloid related, or is there something else? So a repeat renal biopsy was done. So that also was suggestive of a renal amyloidosis, with immunofluorescence negative for IgG, IgM, IgA, and complements. And the interstitium in the biopsy showed infiltration of lymphocytes and plasma cells. So we got a repeat PET scan. So the PET scan showed hypermetabolic mesenteric lymph node with heterogeneous enhancement of the abdomen and retroperitoneal nodes, and subcentimetric mediastinal nodes. The description was the nodes appeared bulky. The hepatomegaly increased from 16 centimeter to 21 centimeter. The splenomegaly was the same, which was FDG negative. There was also FDG mild avidity in the parotid and submandibular glands, with heterogeneous enhancement of bilateral kidney. The likely read was likely amyloidosis. And for the multiple lymph nodes, the diagnosis was likely amyloid deposition. And then we got another biopsy that revealed the final diagnosis.
Eugene, what I'd love to do, since this is our last aliquot, is I would love for you to go grab a towel to wipe off the diaphoresis off your face and then send me one too, okay? But we're going to make that a little bit easier by doing some breakout rooms so that you can share your thoughts and discuss with your colleagues, okay? So we'll just do a nice 5-minute breakout room, and we will reconvene in a few minutes, okay? All right, see you all soon. All right, Eugene. I'm sure you have the answer for sure, certainty by now, right? I'm curious. Oh, you're still muted because I muted you with my my powers. So what was the conversation like, my friend?
Yeah, so we were just trying to figure out what could be the cause of this amyloidosis. I mean,
Yes.
at this point, it's clear to us that it is the consequences of amyloidosis. That is what we are seeing in the clinical picture. But we just couldn't really wrap our minds on
Yeah.
possible cause, and then what really is the next step that we are going to take.
Precise.
But for me, I think just going along the lines of your teaching, chronic inflammation, and we seeing significance of amyloidosis in the clinical picture, you are thinking of AA. But with the plasma cells, then we are not sure where to go to, whether it's AL. And so at the moment, I'm not really sure. Someone mentioned we had to do some immunostaining
Yeah.
to actually diagnosis. So that is where I am at. Very difficult case for me, but also a very great learning point. Honestly, I've not even seen a case of amyloidosis ever in my career. So, yeah, it's just a big learning space for me.
Yeah, for sure. I will tell you, I have a very, very strong suspicion of a very specific diagnosis. But I don't want this reflection to take away from what the purpose of a case like this is, because the purpose of this case is to really understand the bread and butter of medicine to allow you to even propose such rare diagnoses, which I'm about to propose to you all. But honestly, what's the most impressive for me, Eugene, is I think so many people who are in your shoes who are yet to do their intern year, hearing a case like this would wobble, understandably wobble. The fact that you are so cool, calm, and collected, at least on the outside, of just being transparent about how much you know and what you don't know is really mind-boggling. Because I'm going to propose to you a hypothesis, which doesn't matter if it's right or wrong, I'm going to learn either way. But that hypothesis is only because I'm PGY 12 now. No, PGY 11 now. If I were in your shoes, I would probably be like, get me the hell out of here. What is this case? Is too complicated. That's honestly how I would feel. And the fact that you're not is a real testament to what this community is about. But this community is also about a tremendous intellectual rigor to try to even have the hypothesis that I'm about to propose to you. But here it is. Whenever you have a difficult case, you always want to look for the paradox, the things that don't add up. And let me propose to you a paradox. Chronic inflammation and neutrophilia. I said to you all sepsis as a specific marker of neutrophilia to come back to this point now because this patient is densely neutrophilic, 80%, and yet is subacute to chronic. So you ask yourself, what causes a chronic neutrophilia? And here's the paradox. Neutrophilia, acute aggressive, renal amyloidosis, chronic indolent. And so with that paradox, you start to say, wow, maybe I can start to suspect the very limited and unusual number of things that bridge the paradox between Austin's former world, primary care, indolent medicine, and Sam's future world, ER, acute, serious. And this disease on labs has features of both. Dense neutrophilia, that's an ER. Splenomegaly, renal amyloidosis, that's clinic, right? And when you layer in the final piece of information, which is that this patient has bulky lymphadenopathy, what exists in those three orbits is a paradox. Because most of the time, Eugene, when you have disseminated lymphadenopathy and hepatosplenomegaly, you have invasion into the bone marrow causing cytopenia. And so the fact that this patient has leukocytosis is a very, very unusual and characteristic feature of a subset of diagnoses. So what are the diagnoses that are at play here? I think another key filter is the time course. This entity has been slowly eating away at this patient, 0.5 kilogram every month. Infections don't eat away at a patient at 0.5 kilogram a month. Either they do nothing or they do much faster. The same is true for cancers. They don't usually do this. This is a signature of a cryptic, slowly progressive autoimmune disease. And there are two autoimmune disease categories that cause a paradoxical neutrophilia: vasculitis and histiocytic macrophage diseases. This is not vasculitis for many reasons, including the lack of hematuria on the UA. And so I'm asking myself, what kind of macrophage or histiocytic disease explains this picture? And this is where the entity of Rosai-Dorfman disease starts to loom large, in large part because of the bulky lymphadenopathy that extends into the neck, but also because of the characteristic infiltration of plasma cells in that condition. So for me, I think this hypothesis is important to have because, as you said, it requires really close scrutiny of the biopsy. You have to take a whole lymph node out, and you need an expert pathologist to analyze it. And that's definitely what needs to happen here. So what is the core learning here? The core learning is in difficult cases, you want to try to find the water and the oil. Neutrophilia and AA amyloidosis are exact opposite things. And when you put them together, you can really get a small differential diagnosis. The time course here is very characteristic of an autoimmune disease. Autoimmune plus neutrophilia, vasculitis, or macrophage. No vasculitis here. Macrophage often means granuloma, often means cytopenia. Macrophage plus leukocytosis, histiocytic disease. What kind of histiocytic disease? There are three major ones. The one characterized by bulky lymphadenopathy and plasma cell infiltration is Rosai-Dorfman disease. So I would be most suspicious of that, but you have to have humility in cases like this. What we really need to do is to take out a nice big lymph node and hope that we have a very astute pathologist. I think that's probably the key lesson in this case. All right, Vijay, Mike, to you. What ended up happening for this patient?
Yeah, I think this is something that we have discussed previously in the academy as well. So there are few things that were not fitting when I saw this patient. So basically, I just got a cross consult for this patient just because the patient had an intake of antitubercular therapy. So things that were not fitting for me was this indolent amount of inflammation with some plasma cell infiltration. So there are two things that was going on in my head. One was histiocytic disorder. One was possibility of multicentric Castleman's because of the low avidity on the lymph node. That was one thing that I remember taking home from the academy VMR of PET negative nodes being angioimmunoblastic T cell lymphoma and Castleman's. So what was proposed was we went ahead and repeated a biopsy because there is increase in the size in the liver as well. So repeat excision biopsy from the mesenteric lymph node showed features are suggestive of Castleman's disease with a highly vascular variant along with amyloidosis. So this was the final read. There were no any epithelioid cells or giant cells that were seen. So this was the final diagnosis that was given, and the typical onion peel appearance was described. So still a few things are not fitting for us, even though we have a diagnosis of Castleman's, renal amyloidosis at this age. So one thing that was there was whenever we have renal amyloidosis, I learned this from Kirtan. I just discussed this case with Kirtan as well. So doing a the immunophoresis of the for the renal amyloid becomes very crucial whenever we have young patients. So three possible diagnoses apart from AL, AL amyloid and AA amyloid. So one thing that is recently described is ALEC2 related amyloidosis. So that was one thing that we were considering. However, there was no facility in our lab to run for this. So the final diagnosis that we had was multicentric Castleman's with secondary amyloidosis. Yeah, I think
Absolutely.
it was a wonderful discussion. I love the discussion and there was so much learning. Thank you
It's
so
a
much.
fascinating case, Vijay. Absolutely fascinating. Let me stop there and see what reflections you have, Eugene.
Yeah, so yeah, very fascinating case. I think in retrospect, getting to hear the diagnosis, I think the best way I could have approached this case should have I mean, hold on, because where I have knowledge deficiency is the amyloidosis. Where I have knowledge deficiency, it's where to actually biopsy. But I mean, I had an understanding of a patient with hepatosplenomegaly. So in retrospect, I could have just honed on hepatosplenomegaly and then think about what are the various causes of hepatosplenomegaly. And I mean, one of the thoughts was lymphoproliferative disorder. And if we are looking at Castleman disease, which is, I think, is it clonal or non-clonal lymphoproliferative disorder, I could have started thinking along that line. And just as you also said, the neutrophilia plus AAI amyloidosis is not something that goes hand in hand. So it's something that should bring your mind to start thinking about, could this be some disorder of a tissue that is just proliferating and then leading to the production of these neutrophils? And you specifically said macrophages. So it's a very wonderful case, going to take me back to actually sit and then study again on this Castleman disease, amyloidosis. But I'm actually happy that VJ has presented this case. Didn't take any messy on me, just threw me right into the hot waters because I'm able to see where my knowledge deficiency is. I'm able to see where I could actually reason through during the case presentation. And so but another question I actually have, will we have tested? I mean, I don't know if we tested for HIV, HHV8, because I know those can also be associated with Castleman disease. So that is something that I don't know if we tested for that. Yeah.
Yeah. So that was something that we had in our mind as well. HHV8 was a negative in this patient. And I think EBV, CMV, extended viral serologies also were negative in this patient.
Yeah, Eugene, it's amazing how your reflection is so mature, because mine is the same. I think that you ask yourself, like, what knowledge gains can you have from this case? And I think there are many of them. You know, the ultimate answer, especially if the pathologist verified the presence of lymphocytes, plasma cells, excuse me, on this space was gonna be here if we felt it to be valid. So I'll just leave this for you all to study. I think it's interesting to compare and contrast my own illness scripts for multicentric Castleman's, because there are some very interesting features on here suggestive of it, let alone the plasma cell infiltration, but also the fact that the lymph nodes were enhancing on the CT scan, but not on the PET scan. And that happens because enhancement on a CT is a vascular phenomenon, and multicentric Castleman's is very vascular and therefore takes up contrast, but there's not much metabolic activity in Castleman's, as evidenced by the low LDH and the PET-CT avidity. What I have to fine tune about my illness script for Castleman's is I did not include this degree of chronicity in multicentric Castleman's. I had learned that unicentric Castleman's can live on with people for decades. But what I did not appreciate, short of this case, is that multicentric Castleman's can exist in somebody for 2 years, but at least 2 years. He had renal amyloidosis, so maybe even more. And so that is a big, that's why I didn't even hold it heavy in my thinking, because I felt that the time course was relatively inconsistent with it. But yet here it is showing up in this way, which I find so. The story of medicine is increasingly complex and interesting to absorb. Yeah, so very intrigued. A lot of reading and reflection and fine tuning to do, and I'm very grateful for that opportunity. For those of you who are completely and utterly overwhelmed by this case, I think that's the majority. And it goes to show that even if you're studying medicine every day for almost 20 years straight, you can still be humbled. So if you're very humbled, know that that's a universal feature of this job, and hopefully you remain humbled and curious and excited till the day you retire. Thank you, VJ. This is a real gift on the first day of my vacation. I get to read about it for the rest of the week. Thank you. All right, see me, Mike, to you, my friend.
Hello, everyone. Very overwhelming but interesting case and wonderful discussion. And being mindful of everyone's time, I just want to say I'm still trying to pronounce Roside-Hoffman disease. And we have a case of it in February, so just go and check out. And I don't think I have much to add today. Please, Rabih, read about it and teach us. That's what I want to say.
I think the call to keep it simple and real is a very wise one today, Sydney. But I appreciate all the work that you put in to have the concrete teaching points for people to read at their own leisure. All right, guys, take care.